This lecture is about the pathology of female reproductive system. In this lecture, we will discuss the pathology of uterus, including uterine corpus and uterine cervix. Let's remember the histology of uterus. It includes the endometrium, in which we can see the endometrial glands and endometrial stroma. The glands can be in a proliferative phase, secretory, ovulatory, or menstrual phase. We see here under the myometrium is the under the endometrium is the myometrial layer, which is a smooth muscle layer, and the perimetrium. As usual, we start the diseases with infections. We have acute infections, which is called acute endometritis, and chronic infection, which is chronic endometritis. Chronic endometritis can be caused by chronic gonorrheal infection, postpartum, after delivery, post-abortion, or intrauterine contraceptive device. Presence of intrauterine contraceptive device is a common cause of chronic endometritis. Here, histopathological picture of chronic endometritis. You can see here, this is the stroma, and these are glands. The glands shows reactive changes, and the stroma is filled with chronic inflammatory cells, predominantly lymphocytes and plasma cells. Adenomyosis is growth of basal layer of endometrium down into the myometrium, and because the basal layer of endometrium is non-functional, so there is no cyclic bleeding in the adenomyosis. There is no cyclic bleeding during menstrual changes, and it not undergo hormonal changes throughout the layer. Just a non-functional basal layer comes down from endometrium into the myometrium. Here we see not only the glands, but the endometrial glands, stroma, or both. We can see glands or stroma or both. Commonly we see endometrial glands with the stroma from basal layer of endometrium, which is non-functional, see it within the myometrial layer. Here, this is gross feature of adenomyosis. This is the myometrium. Here are the smooth muscle layer of uterine wall. These multiple red spots are the presence of the basal layer of endometrium that comes down into the myometrial layer. Here is the endometrial glands with stroma within the myometrium. This is not a feature of malignancy, it is just a downgrowth. This nest of endometrial glands are non-functional, and they are not malignant. These are the glands and these are the stroma are seen within the myometrium. This is adenomyosis. Now, endometriosis. Endometriosis is a presence of endometrial tissue outside the uterus. The most common site of endometriosis is ovary. Other sites include uterine ligaments, tubes, vagina, vulva, appendix, small intestine, large intestine, urinary bladder, ureter, pelvic peritoneum, hernial sac, surgical scar, particularly scar of previous cesarean section, lymph nodes, and lung. The exact explanation for presence of endometrium outside the uterus is not well understood till now, but there is theories that explain this presence of endometrial tissue outside the endometrium. First theory is regurgitation theory. Second theory is metaplastic theory. Third theory is vascular or lymphatic dissemination. Regurgitation theory means that menstrual backflow through the fallopian tube and subsequent implantation. Menstrual backflow of endometrial tissue through the menstrual cycle, but there will be backflow from endometrium to fallopian tube and then to other sites. The second theory can explain the also presence of endometriosis in the areas that contain the coilomic epithelium, like the ovary. It is the metaplastic theory. The transformation of the coilomic epithelium in the ovary, for example, into another type of epithelium, which is the endometrial tissue. The third theory can explain a presence of extrapelvic or intranodal implantation. It is the vascular or lymphatic dissemination theory. There is detachment of pieces of endometrial tissue from the endometrium, and these pieces can attach to the blood vessels or lymphatic vessels and go to another site away from the endometrium. Grossly, endometriosis is almost always containing functioning endometrium, not similar to adenomyosis, in which the basal layer is comes down to myometrium, the basal layer of endometrial tissue, which is non-functioning and therefore not undergo a cyclic bleeding. Here in endometriosis, the detached pieces of endometrial tissue is functioning endometrium, and therefore they undergo cyclic bleeding, and grossly they will form this is a chocolate cyst. Commonly, as we mentioned, the most common site of endometriosis is ovary. This is a cystic lesion in excised from ovary. It contains a prominent brown area of this is endometrial tissue. It is commonly known as chocolate cyst because of brown color of the lesion, and this is because of repeated bleeding and formation of hemosiderin laden macrophages, and that's why this is called chocolate cyst. And this is because of repeated or cyclic bleeding with the menstrual cycle. Microscopically, we diagnose case of endometriosis in case of presence of these three components, which are endometrial glands, endometrial stroma, hemosiderin laden macrophages. In presence of these three components, which are glands, stroma, and hemosiderin pigment, we confirm the diagnosis of endometriosis. We say that this case is consistent. It is definitely endometriosis. While when we find two components of these three components, for example, we just find endometrial glands and hemosiderin laden macrophages, then this case is suggestive and not definite for diagnosis of endometriosis. This is a case of ovarian cyst. Here, this is the lining of the cyst. This is the wall of the cyst. And here we have endometrial glands lined by benign endometrial tissue, and here we have the hemosiderin pigment. So this case is suggestive of endometriosis. Endometrial hyperplasia. Endometrial hyperplasia is increased endogenous or exogenous estrogen, and this is unopposed by progesterone. Classification: we have many classification for endometrial hyperplasia, and we have a previous classification as a simple complex or atypical hyperplasia. The new classification classify endometrial hyperplasia into two main categories microscopically or pathologically: hyperplasia without atypia and atypical hyperplasia. atypical hyperplasia بحذاتها هي pre-malignant condition، لكن atypical hyperplasia carries high risk for a malignant transformation. طبعا type of carcinoma that occur in cases of atypical hyperplasia is endometrioid type hyperplasia, endometrioid adenocarcinoma. Sorry, endometrioid adenocarcinoma is the consequence of atypical hyperplasia. Here we have two cases of endometrial hyperplasia. We can see a difference between microscopic features of these two conditions. Here we see endometrial glands in its proliferative phase. These are proliferative, crowded, increased in number, but still there is stroma between these glands, and the glands are cystically dilated. This is hyperplasia without atypia. When we see the features, the cellular feature or the nuclear features of these endometrial glands, we can't see any atypia. Here you see the endometrial glands are crowded back to back and leaving no or only minimum stroma between the glands, and these glands lined by cells which show atypical features: pleomorphic, hyperchromatic, high NC ratio, and other features of malignancy. They are crowded and back to back. This is atypical hyperplasia. Now, endometrial polyp. Endometrial polyp are not true neoplasm, but probably a foci of hyperplasia. Usually sessile, hemispherical, not more than 3 cm in diameter. The glands within the endometrial polyp are hyperplastic because they show cystic changes and lined by active columnar epithelium. This mostly occur in perimenopausal women, but in post-menopause, when we see case of endometrial polyp in perimenopausal women or premenopausal women, we can see cystic dilation, and this means there is hyperplastic features. But when we see it in postmenopausal women, the epithelium is inactive, flat, and atrophic. Their significance is production of abnormal uterine bleeding, which is a common clinical feature for endometrial polyp. Behavior is generally benign, and the risk of cancer is present but rare. Here we have endometrial polyp. This is the uterine cavity, and there is a attached polyp. You see here finger-like projection or polypoid protrusion or lesion. We can't say this is a tumor. It could be caused by estrogen effect in perimenopausal women. It is not a true neoplasm, but it can carry risk of malignancy. Microscopically, this is a polypoid shaped lesion which contain multiple cystically dilated endometrial glands separated by this stroma. So this is endometrial polyp. Now, endometrial carcinoma. Endometrial carcinoma arise in association with estrogen excess in setting of endometrial hyperplasia in perimenopausal women. This is the usual presentation: perimenopausal women with estrogen excess. This will give us a microscopic type of endometrial carcinoma, and this is the most common type. which is endometrioid type of adenocarcinoma. It results from estrogen excess, and it is endometrioid type. It accounts for about 80% of cases, while we have another type that occur in atrophic endometrium in postmenopausal women. The type is serous cancer, serous adenocarcinoma of endometrium, which occur, as we mentioned, in postmenopausal women in atrophic endometrium. Generally, risk factors for endometrial carcinoma include obesity, diabetes, hypertension, infertility, and exposure to unopposed estrogen. Any cause, even these causes, obesity, diabetic patient, other causes includes tumors that secrete estrogen, like granulosa cell tumor, polycystic ovary disease, and exposure to exogenous estrogen, which is unopposed by progesterone, is regarded as a risk factor for development of endometrial carcinoma. Others, we have a mutation in mismatch repair of a gene, which is PTN gene. This is also associated with endometrioid type of adenocarcinoma, and not the serous type of adenocarcinoma. In serous type adenocarcinoma, we see mostly mutation of p53 tumor suppressor gene. Grossly, we have two main types, either exophytic, which is polypoid type, or infiltrative ulcerative type to the myometrium. Clinical presentation commonly is abnormal uterine bleeding, menorrhagia, or in postmenopausal bleeding in postmenopausal women. طبعا يعني uterus is not palpable clinically unless there is invasion of myometrium. Microscopically, as we mentioned, we have one major type, and the most common type is endometrioid type adenocarcinoma, and we have poorly differentiated type. طبعا الendometrioid type regarded as a well differentiated type of endometrial adenocarcinoma. We have other poor types. We have, for example, serous type. These poor prognostically type accounts for about 20% of cases. Here we have endometrial carcinoma, an irregular shape mass originating from the endometrium and for the endometrial lumen. It is fungating or exophytic shape, irregular borders. Microscopically, we see here glandular structures proliferation. These glands, this is the lumen of the gland, and these glands lined by atypical cells that show malignant features. And we see here that the glands are crowded back to back, and there is no stroma between these glands. And this is a feature of endometrial carcinoma, in addition to the lining, which is malignant. Now, the staging of endometrial carcinoma, we have two major systems for staging, which is FIGO and the American Joint Committee. Both regards TNM staging system. Basically, both depend on the tumor itself, its size, and the state of lymph nodes, the number and size of the lymph nodes, nearby lymph nodes, and presence or absence of distant metastasis. And we have then we will do the group staging according to these three parameters. pathology, which is the tumors of myometrium. The most common tumor of female genital tract is Gliomyoma. It is benign tumor of smooth muscle origin. It is commonly known as fibroids. Gliomyoma occur in about 70% of women over age of 30, and they are rare before age of 20 and commonly regress in postmenopausal women. This means that this tumor is estrogen dependent. It needs estrogen for its growth and proliferation, and that's why it regress and become atrophied after menopause. This tumor is common in multiparous women and than in nullipara, in premenopausal than in postmenopausal women. Its importance, clinical importance, that its clinical features are variable. It can be asymptomatic. It can cause abnormal uterine bleeding. It can cause infertility, and as we mentioned, estrogen promote their growth. Pathologically, the tumor is firm, pale gray, and whorled. Being whorled is the most important gross pathological feature. It is well circumscribed, but it is not encapsulated. Its size vary from 1 millimeter to over 30 centimeter in diameter, or even 1 meter in diameter sometimes. It can be single or it can be multiple, and the most gliomyomas are intramural, but sometimes being subserosal or submucosal. Intramurals mean within the myometrium, its site of origin. Microscopically, it consists of interlacing bundles of uniform spindle cells, and the nuclei are elongated and have blunt ends as the benign nuclei of smooth muscle. The cytoplasm is abundant, eosinophilic, and fibrillar. Gliomyomas in the similar to adjacent myometrium cytologically, but gliomyoma are easily distinguishable by their being well circumscribed, nodularity, denser cellularity. The malignant counterpart of gliomyoma is leiomyosarcoma, which is a malignant tumor of smooth muscle origin, and we have certain points to differentiate grossly and microscopically between leiomyoma and leiomyosarcoma. The most important is that grossly that leiomyoma is almost always solitary. We find a single nodule within the myometrium. Most of these tumors occur in older age group than in leiomyoma, and tends to occur in postmenopausal women, and there is areas of hemorrhage and necrosis grossly seen. Microscopically, the differentiation between leiomyoma and leiomyosarcoma depends on the presence of these three important points. The most important is necrosis, cellular atypia, and mitotic figures. This is grossly leiomyosarcoma. We see circumscribed large mass which containing areas of hemorrhage and areas of necrosis. Microscopically, this is atypical cells. We see interlacing bundles of spindle cells proliferation. These are spindle cells proliferation. Each one grow in a different direction than the other, each bundle in different direction. We have atypical cells. Here we see pleomorphic atypical cells. Mitosis is present, and here we see area of coagulative necrosis. These are three important features for diagnosis of leiomyosarcoma: atypia, mitosis, and coagulative necrosis. Now, the uterine cervix, neoplasia of the cervix is a very important subject, because commonly it is regarded as a pre-malignant condition, and a common term that is known as squamous intraepithelial lesion or cervical intraepithelial lesion is a pre-malignant condition, and we have a screening program to detect these lesions because they are pre-malignant, and there are multiple centers in which we detect this lesion, and presence of these centers can or actually it lowers the number of cases of cervical carcinoma. دائما يرتبط اسم intraepithelial lesion of cervix with human papilloma virus, and as we mentioned, it is a precancerous epithelial change, which is usually precede the development of an overt cancer by many years, sometimes decades. Here we have a group of changes, or we have a grades of changes before the carcinoma can develop. The progression of one change to another needs a period of time. What is the length of this period? Nobody knows. It depends on the patient. It depends on the changes itself. We diagnose it at low grade or at high grades. This will determine their progression into the malignant conditions. The most important of the squamous intraepithelial lesion is low-grade squamous intraepithelial lesion, which is L cell, and the high-grade squamous intraepithelial lesion, which is H cell. The low grade is equal to CIN1, cervical intraepithelial neoplasia grade 1. H cell involve the SIN2 and SIN3. SIN2 and SIN3 are high-grade cervical intraepithelial neoplasia. Previously, they call it SIN1 as mild change, SIN2 moderate, and SIN3 as a severe intraepithelial changes of full thickness changes. Now we separate SIN1 as low grade, SIN2 and SIN3 as high grade squamous intraepithelial lesion. We put these two categories under the term of high grade because they they need the same treatment. L-cell is associated with productive HPV infection and does not progress directly to invasive carcinoma. As we mentioned, we have steps of progression. These steps starts with L-cell, and this L-cell needs progression to H-cell and then to invasive squamous cell carcinoma. L-cell بحد ذاتها can either regress after treatment or it can progress to H-cell. H-cell demonstrates increased proliferation, arrested epithelial maturation, and lower level of viral replications. L-cell is not treated as a pre-malignant lesion, whereas H-cell is considered at a high risk for progression to carcinoma. As we mentioned that, firstly it starts with L-cell, and L-cell can regress or can progress to H-cell. L-cell needs a treatment and follow-up, while H-cell carries high risk for progression to invasive carcinoma. Here is the progression from normal to H-cell. Here the normal squamous epithelium with a good maturation or normal maturation from the basal layer upward to the surface. Here we have L cell. This is the low-grade squamous intraepithelial lesion. We see the changes are seen only within the basal layer of this metaplastic squamous epithelium. Just the lower 1/3 of this epithelium carries features of malignancy. Poor pleomorphism, hyperchromasia, high NC ratio are seen only within the lower 1/3, which is this is L cell or equal to sin 1. The other layers, we see that there is coilocytotic changes in which the viral changes are seen prominent here. The coilocytotic changes, large hyperchromatic nucleus surrounded by perinuclear halo. This is a typical case of L cell. L cell can progress to, this is sin 1, can progress to sin 2. This is sin 2 and this is sin 3. Both these are called H cell. In H cell is either sin 2, in which we can see the changes, the abnormalities, the atypia involve the lower 2/3 of the epithelial thickness. From the basal layer to this layer, all these cells shows features of malignancy, but still within the lining epithelium. And here we can see in the uppermost layer, in the upper 1/3, the coilocytotic changes, the viral changes. In sin 3, which is also equal to H cell, all layers or full thickness, there is full thickness nuclear or cellular atypia. All cells within the lining epithelium shows features of malignancy, اللي هي pleomorphism, hyperchromasia, presence of abnormal frequent mitotic figures, and there is no coilocytotic changes, the disappearance of coilocytotic changes. Still there is no invasion beyond the basement membrane, and this is H cell, and this is equal sin 3 equal to carcinoma in situ. The cytology screening program is very important in detection L cell, H cell as a pre-malignant condition, and this program, as we mentioned, aimed to detect atypical cells in cervical smear cytologically by cytology. And this is a very simple procedure, safe, non-invasive method to detect precancerous changes in the cervix. This is screening program to detect precancerous condition. So it's aimed to detect the atypical cells as a precancerous condition. The incidence of mortality from invasive cervical cancer has fallen to communities where invasive screening has been carried out. The pap smear remains the most successful cancer screening test ever developed. The name of the screening program or the procedure is called pap smear, in which we take the cells by brush from ectocervix and endocervix and examine them by after staining by a special stain which is called pap stain to detect any atypical cells, and we can categorize the lesion as L cell, H cell, or negative for intraepithelial lesion or malignancy, and according to the result the gynecologist can follow the patient. These are the findings by pap smear. This is pap stain. Here we have normal squamous epithelial cells, normal NC ratio, and normal staining of the nucleus. Here we have a low-grade squamous intraepithelial lesion. We see here enlargement of the nucleus, so we have high NC ratio, we have irregular nuclear borders. In H cell, this is sin 2 and this is sin 3. Both are called H cell. Also, we have more nuclear atypia, this is more aggressive features, enlargement of the nucleus, and here we have a group of cells. This is sin 3, showing a group of atypical cells in which there is a pleomorphism, irregular nuclear borders, and clumped chromatin within the nucleus. Now, invasive carcinoma of the cervix, the most common cervical carcinoma is squamous cell carcinoma, and it accounts for about 75%, and which is followed by adenocarcinoma and mixed adeno-squamous carcinoma for 20%. We have a small cell neuroendocrine carcinoma, which accounts for less than 5% of cases. All these types of carcinoma, whether squamous cell carcinoma, adenocarcinoma, adenosquamous, or small cell endocrine carcinoma, are associated with human papilloma virus. Progression of squamous intraepithelial lesion to invasive carcinoma is variable and unpredictable and requires HPV infection as well as mutation in tumor suppressor gene and oncogenes. Other oncogenes are required. As we know, human papilloma virus cause mutation of most important tumor suppressor gene, اللي هو P53 tumor suppressor gene, RB gene, and other important regulatory genes. So development of carcinoma require HPV infection. As we mentioned, it is a multi-step process. Begins with infection, begins with cervicitis, which is caused by HPV, then progress to L cell, H cell, and then invasive squamous cell carcinoma. Vulva diseases include benign cysts. We have epidermal cyst and Bartholini gland cyst. Epidermal cyst is a keratin-filled cyst, benign, lined by benign squamous epithelium. Bartholini gland cysts leads to formation of a cystic dilation of the duct, and the glands may result from obstruction of the duct by chronic bacterial inflammation, especially gonorrheal infection. The cyst lined by either columnar, transitional, or squamous epithelium, but within benign features. Leukoplakia is a clinical term and is just a descriptive term of underlying different pathological conditions. It means white patch, and it can denotes benign condition, pre-malignant, or malignant condition. Therefore, biopsy should be regarded for any white patch seen for lesions. The differential diagnoses include either, as we mentioned, benign, pre-malignant, or malignant conditions. The benign conditions include vitiligo, inflammatory dermatosis such as chronic dermatosis, chronic vulvar dystrophy, carcinoma in situ, and invasive squamous cell carcinoma. So leukoplakia is just a clinical term which means white patch and can describe wide and underlying lesions that could be benign, pre-malignant, or malignant. Infections of the vagina, mostly caused by white or broad types of microorganisms, including bacteria or fungal infections. Vaginal intraepithelial, squamous intraepithelial lesions of vagina are important because it occur in squamous epithelium, which is native for the vagina and not from metaplastic epithelium as in cervix. In uterine cervix, most squamous intraepithelial lesions that occur are from the metaplastic squamous epithelium, but in vagina it is from the native squamous epithelium, and it is multifactorial. In 50% of cases, upper half of the vagina is the most common site. The most common benign tumors of vagina are papilloma, which is HPV related, Gliomyoma, which is benign tumor of smooth muscles of vagina, and it's commonly described in adult patient. Thank you.